So this is a 21-year-old female presented with history of constipation, giddiness and headache with voiding since 2 years. Sir.
Headache when she voids, is it?
That's what it implies, sir.
Okay, no, it doesn't imply. It would be nice to have it clear. Okay.
Okay.
Headache at the time of voiding is better than headache with voiding. Yeah.
Since the history for 2 years, we want to know the in-between periods, sir, whether she's got the same complaints, any history of any hospitalization for the above said complaints, any evaluation.
Maybe they'll tell you as they go along.
Okay. Patient was apparently ordered 2 years back, followed by episodic attack of headache, palpitation, giddiness, symptoms lasting for a few seconds to 1 minute during the course of voiding. The symptoms coincide with the bladder emptying and relieved just after completion of voiding and peeing test, associated with occasional facial pallor, sweating, tremors, and nausea and above complaints. These symptoms are exaggerated in the past 6 months. I wanted to know history of any LUTs or hematuria.
Why would you be worried about that?
Since the history,
why would you be worried about LUTs or hematuria?
Since the history is more suggestive of any neuroendocrine tumor of the urinary tract. So, but it's a young female, so any issue to
first. Will that add or subtract from the diagnosis?
5G connected. Yes. Check that.
It will add to the diagnosis. The pathology may be from the urinary tract, more from the bladder. That will give clue.
For the sake of discussion, if something is not written here, unless it is very important, we will assume that those symptoms were not present.
Yes.
Okay.
Okay.
What other symptoms would you ask for, considering what you have just said?
I want to know what happens. They are giving only with voiding, sir. Any other than voiding, has she got the same symptoms? Has she been hospitalized for any history of fall? So I want to know the severity, because they are telling only for seconds to minutes. Has she been evaluated since for the 2 years history?
No, so I understand hypertension, headache, voiding symptoms. Other than the urinary tract and cardiovascular, any other symptoms they can have?
Yeah, they may have palpitations, sweating, but she has got all complaints. And she's at 20.
Other than cardiovascular and urinary tract?
Yeah, we have to suspect about the hyperthyroidism, which is also young females. Sir.
No. Considering your diagnosis, are there symptoms other than the cardiovascular and urinary tract which you should ask if it has not been mentioned? They are rarer presentations, but they can be there.
Any pain abdomen's not there.
They can present with, there is a whole list of symptoms if you look at the textbook, but they can present with GI symptoms also.
Okay.
Loose motions, diarrhea, they can have all that. Here she has constipation.
GI symptoms, respiratory symptoms, they can present with psychiatric symptoms.
Okay.
Go ahead. Imran?
Should any storage and virus, no history of prior cervical instrumentation, no history of previous hospitalization trauma, no history of any medication for any systemic illness. Okay.
So who just read out that slide? Is it Ashok? Hello?
Who read out the previous slide? Is it Ashok?
Yes, I myself read.
Oh, okay.
Kamraj?
Yes, sir.
Yeah, Dr. Manish, I think, wants to say something to you.
Yes.
Yeah, so, if you read a slide like that out loud, when you make your presentations, it sounds terrible. So all you need to say is, that I have looked at, say in this slide, I have looked at hematuria, intervention, medications, and any trauma, and there is no contributory factor. So learn to read slides a little better than just reading it out verbatim.
It's no medical comorbidity or thyroid pathologies, and no similar complaints in the past. No significant family history.
Headache, palpitations, and your license.
Either we can't hear you clearly or someone is speaking in the background. Ashok, can you continue? Please, can we go back to the previous slide?
Hello?
The previous one? Yeah.
Hello?
Yeah, Ashok. You have to tell them when to change the slide.
Yes. I've seen the slides. And change the slides. There's no significant family history, similar history.
We can't hear you clearly. Whoever said no family history, please come closer to the mic
So
and maybe you can spread your words out a little.
it's no significant family histories. Personality, sleep is normal, sir. So it implies that only when she's voiding, she's got complaints. Other than that, she's got no complaint.
What do they mean by bladder habits? I've never heard of that word, bladder habits. If it is a urological problem, his bladder habits is what? I don't know whether it is in relationship to the symptom here. You need to emphasize, you need to elaborate on that if it has not already been done in the past. So that's the message here. Bowel habits are normal.
But it's already
It's
mentioned.
better to say what the bowel habits are rather than say normal. For you, to 3 times a day may be normal. For somebody else, it may be abnormal. That's all. So better to specify what they are. Don't leave it blank. And certainly for a urology case, don't say bladder habits are normal. I don't agree with that term. Whatever. If it has already been mentioned that she has got no nuts, then this is an irrelevant statement. To the person who's making the slides also, make it appropriate.
So I'll just add to that. So not relevant to this case, but when you are saying, of course, no mention of bladder habits, of course, but bowel habits is also not adequate history. So if you're taking a lower tract, you're suspecting any constipation, you have to ask consistency, frequency of stools. Does he feel he has evacuated completely? And that is how the history should be mentioned. Not that normal bowel habits or abnormal bowel habits. That's not acceptable for bowel also.
Just to add to that, Manish, it is very important for everybody to understand that there is now enough evidence in world literature and in the studies that there is significant correlation between bowel and bladder function and dysfunction. Many conditions are linked together, and it is important that you understand what the individual bowel symptoms are of a patient. Okay, so plenty of conditions there. Okay, carry on.
So general physical examinations. So patient is conscious and oriented, and this EC with performance status is equal. So good. Pulse rate is 96. Good rhythm, volume, and character. No radial and radial release.
Here again, I have something to say. You see, having given the presenting complaints and history, the first line is inadequate. Dr. Manish referred to the sort of symptoms that a patient might have, given the diagnosis you'll consider. If in a presentation, you refer to those symptoms in the first couple of lines, it tells us that you have thought about those too. If you simply write the same usual thing, conscious, well-oriented, etc., 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 You might be missing out on certain symptoms, which with a subtle history can change the diagnosis sometimes. Given this history, what other general physical examination finding would you be looking for?
Since the patient's main complaints are palpitation and the giddiness, so we have to look for the pulse rate and the blood pressure mainly, that in the different positions and both
But
arms.
you want to see if the patient is anxious, restless, whether the extremities are cold and clammy, whether the patient is sweating.
Yeah, it's mentioned.
Correct.
Yes.
Because if these are present, it buttresses your diagnosis, you'll have less questions asked. And if these are present and you missed it, then misery starts.
Okay, the patient has no evidence of any, in the general physical examination, patient has not got no evidence of any symptomatic activity. Even the pulse rate is good. BP is also normal in the normal range only.
Alright, why have they said radial and radiofemoral delay? Especially in somebody who's got this headache and palpitation, they specifically mentioned radial. I can understand radiofemoral, but why radial?
You have to compare with both arms here.
In the light of the present condition that the patient is suffering from, is there any relevance to radial statement?
Simultaneously, you have to see the pulse of both.
Why? That is my query. Why? Is there any condition where there could be a delay between the right radial and the left radial in a patient who has got headache and palpitation, which is suggestive of some either an endocrine problem or a vascular problem or whatever it is?
It is a cardiac manifestation of the hormones.
No, it's not cardiac manifestation at all. In a patient who's got headache and problem with rhythm, where you're suspecting them to have hypertension, which this lady does not have at the moment, there are specific vascular conditions which give rise to hypertension, which manifest like this, where, like classically aortoarthritis and Takayasu type of syndrome, where the left subclavian is invariably stenosis, and therefore there will be a delay between the right radial and the left radial. So that becomes significant in a situation of this nature. So that is the reason why I asked you that question of radial, so that you can understand what is the problem. Of course, the BP being 100/60 would negate probably a diagnosis of some hypertensive issue in such a patient. It's possible that she may be on treatment or whatever. We have no idea, but it's like, these are things that you must be thinking about in your mind.
It's no failures.
Okay, whatever.
And patients well oriented with time and it's not in function. It's a general physical action that's no contributive evidence.
All right, carry on.
I would not like to know the other examinations, cardiovascular.
What examination would you avoid doing in a patient with this history?
Sorry, what is the question one? What examination?
Would he avoid doing in a patient who presents with this history? Is there any modification of the routine examinations that you do, or would you carry on as if it was any other patient?
For abdominal examination, we have to be a bit careful, sir, because here we are suspecting a paraganglioma, the urinary tract.
Okay.
So it may be provocative.
So what else? Any other condition you would like fulfilled before you examine?
The bladder should be emptied, sir, because patient always gets the symptoms with.
Yeah, she presents with a history of headache and other symptoms when she's got a full bladder and voids. So you would request the patient to finish voiding before you start examination and gentle on the abdomen. Okay.
In a patient like this who has got this history, where you are suspecting probably micturition syncope, is there any other general physical examination finding which has been left out, which might add some strength to the diagnosis?
Maybe that will be syndromic association also.
So what? Like what?
Look for the neck parathyroid and
Next, parathyroid.
neurofibromatosis.
Neurofibromatosis. That is more important. That is more important where you have a situation where there are multiple neurofibromatosis, hypertension, paraganglioma is one variety versus another variety, so it's possible. And also look at the skin, whether there are any caprolae spots, those syndromic conditions where you have a patient who is classically presenting with problems during voiding.
If you have the time and you're very particular, you could also look to see how the capillary filling in the nail beds is and whether the extremities are cold and so on. But again, don't put this pallor cyanosis clubbing as a generic set of findings when you have a patient in whom you suspect this kind of a pathology. It always works better when you mention what you've looked for and found or not found.
Okay, go to the next slide.
Next slide. Dr. Abdomen, no contributory findings. Genitalia is normal, rectal is also normal. And cardiovascular system and skin is stable.
The patient was a female, right?
Yes, sir.
Yes, sir.
Anything missing in the history?
The menarche history and menstruation history is not this.
Yeah, you'll get killed if you don't ask reason. Menarche, menstruation, pregnancy, abortions.
Especially in a lady like this, pregnancy would create a serious issue. So when you have a red flag of this nature, automatically certain things will happen. These are rare conditions, but nevertheless, they are important conditions, and everybody has heard of this term. Although not everybody with micturition syncope has got a PO or a paraganglioma of the bladder, we have to keep that in mind when the history is pretty typical. Carry on.
Urine analysis appears normal.
Okay.
The diagnose RBCs in mills. This also looks normal. Urine culture, it's no growth.
Right.
Hemoglobin is 11.9 and all other parameters are normal. Interior female history
Yes, yes.
more suggestive of the paraganglioma of the urinary tract. So
Yeah.
we need a diagnostic for in the form of metabolic evaluation and radiologic evaluation.
What evaluation?
Functional for metabolic.
When you're suspecting a paraganglioma, you need some investigation. What are they?
Both radiological and metabolics.
Okay.
Metabolic, I want to do metanephrines, plasma metanephrines or urinary metanephrines.
Okay. Have you got those values? Go to the next slide.
Serum cortisol 3 points on microphone. Urinary total metanephrines 132. It's more than the normals. Both are. Should be per day or pills, not total.
Huh?
Should be per day.
Yeah, they have told for 24 hours, but they would have calculated on the volume and then put it per day.
So both total metanephrine and total normetanephrines are very high.
Very high. Okay.
So give the localization of the lesion now.
So
Like
Just to provoke you,
why have they done a cortisol? Why did they do a cortisol?
so
would you do a cortisol?
only when we have adrenal lesion we suspect. So
Now, how do you know whether it's adrenal or not?
No, we
we
don't
don't know
know.
whether it's from. That's why we need to.
No, is there any adrenal cortical situation where you can have this sort of a presentation.
Plain adrenal cortex will not have this.
Highly unlikely. Highly unlikely. But if there is something in the if there is an element even of Cushing inside here, which can actually give rise to hypertension, which can give rise to myriad other complaints. We don't have a clinical suspicion of that on the physical examination. And therefore, a serum cortisol may seem out of place at this point in the exact diagnosis. Okay.
It's a different matter what you do, perhaps in your OPD or clinic when a patient comes like this,
Okay.
and what you'll include in your presentation in the examination.
Okay.
If, for example, the cortisol is a little out of the range, then you're in trouble. Get it?
Yes, sir.
Yeah, let's move on, please.
Carry on, carry on.
Is this slide from KKCC?
Yes, sir.
And next time, please make sure that you don't crowd the screen. Sometimes it's very easy to miss out small findings.
Yes,
Try
sir.
and see whether you can get 4 or 6 images in each screen,
Yes, sir.
and then we can go through them in greater detail.
Yes, sir. Next slide is there, sir.
For my information, what is KKCC?
Kalyani kidney.
Kalyani Kidney Care, sir.
Oh, Kalyani Kidney. Okay, right.
Next.
Don't waste time, please.
Next
Carry on,
image.
carry on.
Kamraj, you should tell them to move on if you're done with looking at it.
Okay, next image. Next image.
Really spread out, as well as being sort of stretched like elastic.
It's next image.
Suggestion, Kalyani residents,
Yes, sir.
if you're getting these images from an outside imaging agency,
Yes.
you can ask them to give you the DICOM files on a CD and then splice individual images for the presentation.
Okay, sir.
Okay?
Okay, sir.
Because since the image is small, if you spread it out, it distorts a lot of things.
Okay, sir.
Next slide, sir.
You find here, don't move to the left slide. Go back, please. Yeah, Kamraj, you have to tell us what you find.
In this slide, the bladder shows a hyperintensive lesion in the anterior wall of the bladder, sir. Otherwise, the bladder looks a normal shape and the contour, except for the anterior wall where there's a lesion, hyperintensive lesion. And
Okay. Okay.
the previous slides, both the kidneys were looking normal, but the right kidney was placed low in the low position. And the adrenals I couldn't see properly in that.
That's all right. You can interpret these images.
The bladder shows a lesion in the anterior wall, sir. Hyperintensive lesion. That's
If you're done, you want to move on, move on.
signs are preserved and there's no any other signs of perivascular involvements.
In this case, will you be interested in perivascular involvement or something else?
There's no other tumor, only single.
Yeah,
single-
you would be interested in knowing whether there are other
This
tumors.
lesion appearing to be intravesical.
It's not going into the lumen, sir.
It's very important because if you see ordinary TCCs of the bladder, you can see that they are intravesical. But here you see that the bladder contour is maintained. So whatever is there is probably in the wall of the bladder, and you can see the anterior abdominal wall there, and you can see the bladder wall correctly. You can see very nicely being indented in the contrast images there. All right. So this is obviously something between the layers of the detrusor. All right. She doesn't look to be a very fat individual considering the amount of the space between the anterior abdominal wall and the skin there. So she's a thin person. Is there any difference between the image on the right side, which shows it to be intense, and then the image on the right side just below that?
There's difference.
What is the difference?
Enhancement has come down.
Why is it come down?
See whether they've done any washout protocol.
It's possible that during the filling, during the time of that, when the bladder was filled with this contrast, there must have been a stimulus vascular lesion and therefore it may have washed out. Otherwise, it should have retained that. The very fact that it's very hyper intense on the, I won't use the word intense, increased density there, or extremely vascular lesion there. And then it's sort of disappeared when the bladder is getting more and more filled. So obviously the contrast is being washed out. What are the other areas you will look for in a situation like this?
For the urethra, urethra, renal pelvis, ureter, those are the other common sites for urinary tract paraganglioma.
Yeah, urinary tract paraganglioma you can get in the. Apart from that, don't forget to look at the aortic bifurcation. Don't forget to look at the adrenal gland. And in fact, you can even have it in the mediastinum. Anywhere it's possible. So,
since the diagnosis is more favor of urinary bladder pheochromocytoma, I need to do a functional imaging because she's a 20-year-old female.
yes. So what will you do?
Either you can go for the FDG PET or the MIPG.
FDG PET. How will a FDG PET help you here?
Since we are anticipating urinary bladder, FDG is not recommended.
Then you're saying FDG PET.
For other,
No. This is there. You want a functional study. What is the classical functional study that they are doing for this?
MIPG.
MIBG. Then why did you say MIBG? Why you bring in FDG now? MIBG scan is necessary to address. Is MIBG apart from diagnostic any other value?
It's useful for reference and
No. Is it of any other value? MIBG scan.
even for therapy.
Yeah. So this is for a procedure for theranostics, therapy as well as diagnostics. MIBG. Is there any other molecule that you know which would help you in which is now moving on for making diagnosis of these sort of lesions, which are in the category of neuroendocrine lesions?
Gallium-68 dotatate.
Dotatate scan, yes, that is the important thing that has now come up where you can use it. But I don't know whether they've done an MIBG scan or whatever. So.
The MIBG scan can.
Hello?
Hello.
Kamraj, your voice is very muted. Maybe that's why they're unable to hear you.
Yes, sir.
I don't know whether they're on there.
I think the Imran would be on.
I would like to do MIBG scan, sir.
Next slide, please.
No.
The question is, has a MIBG scan been done? Can anybody from Kalyani Ashok, can you answer that? Ashok, are you on?
It's been done, sir.
Yes.
Yes, Kamraj, you've got the scan.
There's intense trace uptake in the urinary bladder region, sir. Apart from the physiological uptake, the liver and the proximal small intestine.
In which organ in the human body are these cells not present? You said physiological in the liver and a little bit in the spleen and all the rest of it. But there's very intense uptake in the region of the bladder, which matches the CT scan. But which area of the human body does not have any of these cells at all? Which makes it an important issue when we are looking at whether these lesions are malignant or benign. This can be malignant also, isn't it? So, makes a difference. Of course, nowadays there are other ways to know if they are malignant at all, but this is a pretty spot on situation where if it involves and you know that it is there. Yep. Lymph nodes. The lymphatic system does not have any chromophylls. And therefore, if you find in the course of your evaluation or in the course of surgery that you find lymph nodes, then it is 100% metastatic. All right? Of course, now the criteria have changed. It's not necessarily only in the lymph node. There are other criteria for labeling somebody as having a malignant pheochromocytoma. That is something you all need to look up now. Before the day is done, what are the criteria for calling somebody having a malignant pheochromocytoma or malignant paraganglioma? So what will you do now?
Since the diagnosis is confirmed as a paraganglioma of the bladder, so we need to do a surgical resection. So either you can go for after adequate preparation of the patient.
What is the adequate preparation?
You need to.
No. What is this adequate preparation you are talking about?
BP. BP, blood glucose level, BP. And even the cardiac status should be normal.
That's all. You just it should be normal, BP should be normal.
What is the most critical physiological parameter which will tell you that yes, preparation is adequate or not adequate?
So the BP should be optimist 120 or 130 or 87.
Yeah, but BP might be optimal. Is there anything else which can actually affect intraoperatively the outcome of surgery? So there is considerable volume contraction.
Or whether you have a few of the adrenal or a few anywhere else in the body, it poses both anesthetic and surgical risks. You need to make the patient fit for the surgery as well as the anesthesia. And there is a very clear protocol for that. So that's what I want to know, because tomorrow these patients will come to you. They've got urinary trouble. What do you do? Of course, the easiest thing is to send to endocrinologist.
1 to 2 weeks OP we have to treat as well. Then 1 to 2 days prior to the surgery as inpatient we have to manage the patient.
If the patient has come today on the 28th of July, when do you think you should plan her surgery?
In another 2 weeks.
2 weeks. So you've got to get in 2 weeks certain things with more as 1 week. What are the things that you would like to do?
One is the BP control, and another is blood glucose.
The BP is already normal, 100 by 60.
Yeah, that's depending upon the BP only we change to OPD courses 1 to.
What else is happening to her? What else is happening here?
That's a point, Kamraj.
She has got tachycardia, 96 pulse rate.
She's got tachycardia and other things that you didn't look for.
So she has to have blockers.
These are volume contracted patients. Okay, Dr. Ganesh has been driving the anesthesia bit again and again. So the goal of management, BP control, heart rate control, volume expansion, and then surgery, and of course intraoperative management.
The question that Dr. Mohan asked is, when will you know that the volume is fully expanded? Is when you check the hematocrit, simply, very simple. Hematocrit will drop and then you say, oh, okay, the volume is now okay. Then you look at the pulse rate, you see how it is, whether it reaches a steady state. Okay? And then you can proceed informing the anesthetist that this is what it is. So will you do this endoscopically? Or will you do it by an open method? Can you resect this, please?
sir, but endoscopic is reported, sir, but I think this tumor is more amenable for partial or total cystectomy.
Total cystectomy?
Partial cystectomy, like some mainly.
No. Please be careful of the words that you use. You can't say partial, this patient is amenable for partial or total cystectomy. That word total cystectomy should never come. Will you do a cystoscopy on this patient?
Not necessary, sir, because
Think physiology again, Kamraj.
this is not.
When will you do a cystoscopy? Devil's advocate.
That's any of the imaging doesn't show any other tumor, even she has got no immaturity.
So the urine microscopy does not show any RBC. Microscopy does not show RBC. The CT scan is pretty certain, okay?
Yes.
And you know that the very act of distending that bladder might actually give rise to another
Surgeon.
episode, in spite of the fact that the patient has been blocked adequately, could cause a problem. So you don't want to vitiate that. Okay, so a cystoscopy is not mandatory in this patient. Okay, probably many people would do a quick scopy in this patient without over distending the bladder, just to make sure that you know which way you're going to go. Usually these things are better not resected transurethally, although some people have reported, yes. And it is better to do a complete excision of this lesion. Either you do it robotically or you do it laparoscopically or you do it the open. Whatever you want to do. So this requires a excision, wide local excision of this lesion, and you get it. What do you think is the outcome of this operation?
Outcome will be good, sir, but since she's a 20-year-old female, we should go for
What?
genetic screening.
Genetic screening. Is there anything else to suggest that there could be a genetic abnormality?
No other.
That you would have found out in the clinical examination. If there is history of fits, anything else in the brain and all that, that sort of thing in the history. Headaches. The headache may be due to this, the headache may be due to something in the brain. So many people would probably, in a younger person, if there is, they want to be sure there's nothing in the brain because that is very vital. So they may do an MRI for such a patient to just make sure that there's nothing happening in the brain. We want an unforeseen situation. All right. So,
If you had the choice, what would you have done? A CT, an MRI, a MIBG scan, what would you have done?
listen to the question and answer it very carefully. It's a question you understood. If you had the choice between CT, MIBG, MRI, which is the one that you would choose? MIBG. Can MIBG be negative?
Whole process itself was only for
What is the goal of imaging, Kamraj, in this? Let's begin from there. What's the goal of imaging?
any other lesions apart from the bladder.
First of all, you want to see the primary lesion,
primary and any other.
right? You don't just want to see it, you also want to see where it lies, what is in the neighborhood, right? Whether you can get margins, and then you want to see which other organs or which other structures are involved, the extent of involvement. To meet these goals, which would be the ideal imaging investigation, which might also tell you the nature of the tissue that's giving rise to this mass.
And MRI will be the better.
Yeah, okay, keep that in mind.
You know, a very good diagnostic assessment, as well as a looking at wherever it is. You know, you don't know where exactly it could be. So both anatomical as well as physiological. You've got a classical what? Light bulb appears. Which image?
T2 images.
T2 edited. Right. Okay. So you know this is a classical situation where an MRI would probably have been more beneficial in a patient like this, where especially your index of suspicion is very high. But certainly the CT has given us the answer. but MRI would probably have been the investigation of choice. So what was done for this lady? KKCC,
Ashok,
KKCC, what was done for this lady? Hello? All right.
hey, they've fallen off the radar. They're not here at all.
Prabhakar is not paying his internet bill again.
Sorry?
Prabhakar is not paying internet bills.
Either that or restored his residence.
So what is that, laparoscopically or open?
The connections.
Oh, your connection is not good.
KKCC.
KKCC, yeah.
Yeah, he's been transmitting live, so I don't think his connection would be all that bad.
Anyway, it looks like really had.
Otherwise, sir, what would you prefer, open or lab?
It's small, it's 2 centimeter lesion, 2.5 centimeter lesion. Sir. So it can be done both open and lab.
Yeah. It can be done laparoscopically, it can be done open, it can be done robotic, anything. But this is certainly not a TOR specimen, isn't it? That's not a TOR. Right. Okay.
So what would you expect the pathologist to report?
What do you want the
What
pathologist to do?
pathologist report on this?
The mitotic rate and cellularity and we require immunohistochemistry also.
Right. It's important because now we are looking at whether this lesion is absolutely benign or whether it is malignant. I don't know what are those 2 bits of tissue that are there. What is that? Are there any lymph nodes in that? Hello?
They're not there.
Not this.
Oh, they're not there. Right. Okay. So we don't know whether those small little things are some lymph nodes or some perivesical tissue. But you can see here that there's a homogeneous appearance to this. All right. The important thing is I don't see any areas of what? Necrosis. I don't see any hemorrhage and necrosis, which is pretty typical of a pheo. All right. If you look at pheos, you'll find that there's a lot of areas which are, lakes of blood and stuff like this. Looks like a solid lesion. So this is most likely to be a paraganglioma of the bladder. It could well be even a neurofibroma of the bladder. The only thing, neurofibromas also can give rise to some degree of all this palpitation and functional change. So that is the situation here.
Do you have the histology report?
So it looks pretty benign, no? There is no mitotic. I was telling you about the mitotic rate and that is one of the features of a malignancy. They look at the mitotic rate and there's a nuclear cytoplasmic ratio index. It goes by somebody's name. And I forget that. So, these are things that are now available to look at whether a lesion is actually malignant or benign. Okay.
Adrenal Pheochromocytoma Paraganglioma.
So they have to look at all these features. Okay. Immunohistochemistry may be useful and all that because this lady can have a recurrence later on somewhere else. Huh? Oh, there's a cyst. That was a cyst arising from fallopian tube. So a simple serous cyst. Now this is a 21-year-old girl, isn't it? Unmarried?
Not stated so, but we presume.
No, but I'm just concerned that the cyst from the fallopian tube will grow. I wonder what happens to the fallopian tube.
Exactly.
Was it necessary?
Exactly.
Anyway.
And because the hazards also lie in the risk of an ectopic pregnancy if they meddle with the tube.
It doesn't look very big.
All the more very simple.
So, specimen labeled as margin blocks are free from tumor. Okay.
So, suppose this patient came to you in the second trimester of pregnancy with all this.
Good question. Second trimester. Why not the patient come in the first trimester itself? But he specifically asked second trimester, I can understand why. Anyway, so go ahead. How will you answer that question? Patient has come in the second trimester of pregnancy.
And the second trimester can be optimized and go for surgeries. In the second trimester, you can go for the surgical procedures.
No, many cases.
The second trimester, you can take her for surgeries after adequate optimization.
No, what about the pregnancy? What about the pregnancy? He's a second trimester of pregnancy. So what are you going to do? Pregnancy can be covered. What about the mass?
Second trimester, you can go for surgical visit.
It's a very loaded question that Dr. Manish has asked. And unless you have read about this issue of pheochromocytoma and pregnancy, you will not be able to answer this question. These are rare events. Remember, this is arising from the urinary bladder. The uterus is sitting on it. The bladder will distend. It will press on this damn thing, and she will have problems. Blood pressure will shoot up. The fetus inside is going to be in deep trouble. So the first thing is you may have to keep this lady on catheter treatment. It is not void. Secondly, what are you going to do with the pregnancy and this lesion? Many years ago, they did not know how to handle this. So they took the tumor out because that was causing the problem, and they lost the baby. They lost the baby. They lost the mother. They lost the mother too. Then they looked at these problems and they decided that in a patient who's second trimester, go through till the child becomes viable. Nowadays, of course, viability is, excess. But keep going. Do not discharge the patient. Keep the patient under close surveillance. Keep the patient in hospital or wherever you want to. And at the right time, do both. At the right time, you deliver and take this tumor out, both simultaneously. So a cesarean to take the baby out and this. I'm telling you this because I have the experience of this. That's all I know. Nothing else. I read about this and we had this problem, and subsequently we had 2 or 3 more situations like this. So we learned from that. We had to read up before so that we didn't lose the baby and the mother. His mother came actually from Trichy. It was a pregnancy, it was a precious baby. We had to admit her. She was exactly she came between 6 and 7 months of pregnancy. We had to admit her. And this was arising the kid. So we had to do this plus the adrenal pheochromocytoma. It was not a bladder pheochromocytoma. So both had to be done. And both were safe. So that's how it took a lot of preparation, interdepartmental, gynae, obstetrics, gynae, urology, anesthesia. And we had to very closely watch this lady. They would monitor fetal heart, so that at any point in time you could go in but had to be controlled. There's no contraindication in giving these drugs in pregnancy to control that non-adrenal excess. So there's no drugs. The important thing is that, and monitoring the fetal. What, Manish, anything else? It's a very good question.
Yes, I just wanted to emphasize that you will not do a normal delivery, you will not rush in and do anything, you will probably wait out the pregnancy.
Don't rush and take the tumor out.
Yes, and do both together. You have to do analysis.
There is another risk which one has to be careful about. Beta blockers can cause uterine relaxation. So if one is doing a cesarean at the same time, you have to be careful about postpartum hemorrhage. Similarly, giving tocolytics to preserve the pregnancy and then having to do a cesarean has its share of problems. These are some of the things which call for a multidisciplinary involvement, like Dr. Ganesh was mentioning, to see that things go well for the patient, for the baby, and for the tumor.
These are types of patients who will come to a large institution. And it's probably better that patients like this are referred to a place where they can be handled together in a multidisciplinary team. There are rare cases and they should be handled properly. So, I think that's why, because another lady from North had come with same problem. So since we had the experience of this lady from Pichi, we were able to handle that better. Now there are lots more advances which have taken place, people monitoring and all that stuff.
Comrade, we have a little time, so I have a few questions for you.
Yes, sir.
What drugs will you give this patient when she first comes to you to prepare her for surgery?
First, we have to give alpha blockers, sir. Phenoxybenzamine.
Sorry?
No. Sorry, sir. No.
We have to start with the alpha blocker, sir. As an OP patient, 1 to 2 weeks prior to surgery.
Okay. You start with phenoxybenzamine or whatever else you want to start with.
Yeah.
And then what happens?
The BP we have to look for the BP control, sir. Target BP. So
What happens when you alpha block and cause vasodilatation?
The BP falls. It's 120. We need to
BP will fall. Anything else?
Anything else will happen.
There's something called Bainbridge reflex or something. BP will fall. What is the undesirable consequence?
BP increases the
tachycardia.
Okay.
So how will we manage that?
That beta blockers.
Wait, Praveen, let him answer, Praveen.
If at all the
Kamlesh, he also has to face the exam.
If there is reflex tachycardia and arrhythmia, then you have to start.
How will you know that there is adequate alpha blockage, and so now you can start the beta blockers? You can't do them together. It has to be sequential.
There should be no reflex tachycardia, sir.
No, tachycardia is invariable.
Until then, we have to step up the dose of the phenoxybenzamine.
Correct. When will you know that you have achieved adequate alpha blockage and you now have to move to something else?
That should be mild postural hypertension, sir.
Yeah. So it is a clinical test. If we find there is tachycardia and there is a postural fall, that is the time when we would start beta blockers. What happens? Why can't we just give beta blockers? Why all this alpha blocker chakkar?
Alpha blocker, if you give beta blocker, then there will be unopposed alpha actions, alpha receptor actions.
Yeah. Okay. So physiologically, the action on the peripheral vasculature is different from action on the heart, and therefore we'll first need to treat the peripheral vasculature and then manage the heart. Intraoperatively, what drugs are important? I know you won't manage it, this will be managed by the anesthetist, but exam they might ask you this. Not all pharmacies might stock all drugs. So what are the drugs you will keep ready for the surgery?
One is volume expansion. There should be adequate volume expansion before the surgery.
Correct. How will you do that? How will you achieve it?
1 to 2 days prior to surgery, we need to give 1 to 2 liters of IV fluids.
Let us assume, Kamraj, you've done all that, you have decided you're operating today, right? So what all would you have ready with you in the OT in terms of drugs?
We need to have IV calcium channel blockers.
IV calcium channel blockers. Why? Maybe you should speak to your anesthesia friends.
Clear the drug which will quickly drop this surge that can occur when you fiddle around with these tumors in spite of adequate
Sodium
blockage.
nitroprusside. Sodium nitroprusside.
What else? Sodium nitroprusside is like alpha blockers. Is there any equivalent of beta blockers that you'll have ready? The patient develops tachycardia.
Give metoprolol.
Polar.
Metoprolol. How do you give metoprolol? Praveen, let him answer, please. What is the drug anesthetists classically use?
That reduces the heart rate.
It has to be short acting, it has to be available intravenously, it must be safe to give repeatedly, and it must be excreted rapidly. Right? So look this up, see which beta blockers fall into this category. What problems can you get after the surgery is done? Oh, that surgery, BP well controlled, everything fine. Patient is okay. Can be left alone in the ward.
Hyperglycemia.
What else? See, hypoglycemia and all that will have happened during the initial phase of management. Now surgery is done.
We have hypoglycemia also, sir, because of the unknown post-surgical resection that will be previously hyperglycemia will be there, so rebound hypoglycemia happens.
What else? Which can be an acute life-threatening situation. They have breathing difficulty, they start coughing. They can develop flash pulmonary edema.
Oh.
Okay. We've removed the tumor. There can be circulating catecholamines, which can cause this. And therefore, this patient requires to be monitored for pulmonary edema also in the postoperative period and can't be left alone because we've got the tumor out and the BP is controlled. Will the patient require any follow-up?
The patient requires follow-up for recurrence. So there
What?
are guidelines.
Sorry?
There are no strict guidelines, sir, but we have to do initially for the 6-monthly metabolic workup, and after that annually we have to do 5
year to 6 months?
The follow-up is there. The follow-up will depend on the exact final histology, whether this is benign clearly or is it malignant. If it is malignant, then you will have to evaluate as to whether you need to give any more MIBG as therapeutic. All right? And that will depend on the Ki67, you look at the nuclear mitotic cytoplasmic ratio. Those are the factors which will tell you, and is there any mets anywhere else? Huh? So that will require a follow-up. So the biopsy report is crucial here to decide whether you want to continue. If the lesion is clearly benign, there's nothing more you need to do. You just do one value of this normetadextrin to see if it's all right, and after that, there's nothing to do. Leave it. As long as the patient is not syndromic, if it's just an isolated incident, that's it. Alas, no more. The results are very good, and they are very good outcomes. So you don't have to worry about follow-up for the standard, solitary, either adrenal pheo, paraganglioma, anywhere. One thing is very clear. These are rare cases, but if at the exam time, that department has got a PO, it will be kept. 100% it will be kept, just for them to know, for them to ask you the management and all these other issues that were exactly discussed. Okay? So it's very important that you, in the endocrine urology, this is the most important condition.
Kamraj, what are the ISC markers which you ask for in such case?
K67, sir. K67.
What immunohistochemistry markers will you ask for? That's the question.
The K67, sir.
K67 is a proliferative marker, specific for NET.
Look for chromogranin ES. That's also.
Chromogranin and synaptophysin.
Synaptophysin.
Okay, folks, I think we've reached time. Manish?
Yes, sir.
I think we can wind up.
Yes.
Okay, Okay, thank you, folks. Nice case. In the background, please find out why KKCC is having